Okay. Hello, everybody. I'm Victoria Van Ringemorter, and I work in the Department of Anesthesiology at Clinique Universitaire Saint-Luc in Brussels. On behalf of the BeSARPP, I'm very happy to welcome you tonight to this MSD-sponsored webinar. So we are here to address the key topic, that is neuromuscular blocking agents, these drugs that we inject pretty much every day in the OR. And even if these agents and their monitoring are really not new to us, we still have way to go to improve patient care. So in this context, both the European and the American Society of Anesthesiology have just published some new guidelines. So to discuss the topic, we're very lucky to welcome two anesthesiologists who have been dedicating a lot of their time to neuromuscular blockade. To the audience, feel free to use the Q&A button to ask for any question, and hopefully we'll have time at the end of the presentations to answer them. So a little change of plans. We had to switch orders because Dr. Guy Camus was retained at his hospital. So we'll start by listening to Dr. Philippe Dubois. Dr. Philippe Dubois works at the Centre Hospitalier Universitaire Namur, site universitaire de Godine, mainly as an orthopedic anesthetist. He's also head of the acute postoperative pain service. Philippe Dubois has been interested in the development of neuromuscular transmission monitors since 1999. Also, as Sugamadex appeared on the market, he's been focusing on the optimal management of intraoperative deep neuromuscular block. Dr. Dubois, I will now let you start your talk.
Thank you, Victoria, and thank you, BeSARPP, to organize this webinar. And good evening to everybody at work or at home. And let's start immediately by sharing my screen. I guess and I hope this works. So let's start immediately with a good news. The brand new guidelines from the European Society of Anesthesiology and Intensive Care has been published in the European Journal of Anesthesiology just a few weeks ago. And today, with the support of MSD, I have the pleasure to present you this very important publication with the goal in mind to help you to implement it in your clinical practice. Please have a quick look to my disclosure slide. I have no conflict of interest with the present symposium and lecture. Why am I so happy to present you these new guidelines? Well, the residual paralysis and the critical respiratory events in the recovery room are risk factors of developing postoperative pulmonary complication like atelectasis, respiratory infection, or failure. This problem will be addressed in much more details by Guy Camus, but it is the reason to change our practice. Because the incidence of postoperative pulmonary complication, let's say PPCs, CZR, has been evaluated in several studies with variable results depending on the definition of PPC. Among them, this popular study was dedicated to assess the incidence of PPC after the use of muscle relaxant. It included almost 23,000 patients from 28 European countries. The overall incidence of PPC after general anesthesia was 7.6%. But interestingly, the administration of muscle relaxant was significantly associated with an increased risk of PPC. Moderate or severe PPC, including pneumonia and respiratory failure, reach more than 5% of patients receiving muscle relaxant during major surgery. This has a huge impact on the length of hospital stay, the cost of care, and of course, mortality. Surprisingly, this popular study concluded that the use of neuromuscular monitoring and the administration of reversal agents were not associated with a decreased risk of PPC. This conclusion required a closer look at the data collected. Among the 23,000 patients included, 27,000 received muscle relaxant, but neuromuscular monitoring was applied only to 10,000 of them. 8,000 did not receive any reversal agent, and only less than 3,000 were extubated with a documented tough ratio above 0.9. This represents only 16% of the population investigated. This closer analysis revealed a very high incidence of inappropriate management of neuromuscular blockade in Europe, which could undoubtedly lead to residual paralysis and post-operative complications. This was the reason why the European Society aimed to review the literature and provide the clinician with the recently published guidelines to improve neuromuscular management. A task force of experts was assigned to select and analyze 88 studies in order to answer some clinical questions and propose clear recommendations with their grade of evidence. The first question was, is the use of muscle relaxant necessary to facilitate tracheal intubation in adult patients? Remember that the intubating condition, as perceived by the anesthesiologist, has been rated in excellent, good, or poor condition according to the ease of laryngoscopy, the vocal cords position or movement, and the diaphragm reaction or cuffing. Notice that good or clinically acceptable condition includes fair laryngoscopy, moving vocal cords, and less than 5 seconds cuffing. Even worse than that, you will agree that poor intubating conditions are definitely not clinically acceptable. In the study collected by the European Task Force, the incidence of poor intubating condition was significantly higher when not using muscle relaxant. Intubation could include pharyngeal and laryngeal injuries, pain, and hoarseness. It is significantly more frequent when intubating patients in the absence of muscle relaxant. Notice that these injuries could also occur after a long ventilation period or even after extubating the patient if the patient is coughing or bucking against the tube. Then, of course, the European guidelines recommend with the highest grade using a muscle relaxant to facilitate tracheal intubation. This can help to reduce pharyngeal and laryngeal injury following intubation. For the same reason, they also recommend to use appropriate dose of fast-acting muscle relaxant for rapid sequence induction, such as succinylcholine 1 mg per kilo or rocuronium 0.9 to 1.2 mg per kilo. Second question. Does the depth of neuromuscular blockade influence the patient's outcome? The question has been addressed in different surgical procedures during the last 10 years. And yes, a deep block, that is no response to train of thought, demonstrated in several studies and meta-analyses like this one to improve the surgical condition as evaluated by the surgeon, especially during laparoscopic surgery. A better surgical condition helps the surgeon to work without abdominal wall contraction in an optimized laparoscopic space induced with a lower intra-abdominal pressure, which could reduce the peritoneal inflammation and consequently contribute to lower postoperative pain. But repeated boluses of muscle relaxant increase the risk of patient of developing postoperative pulmonary complication, like nicely demonstrated in this study. In this regard, a deep neuromuscular block undoubtedly improves surgical condition and is the only way to prevent sudden unacceptable abdominal wall contraction in all cases. But on the other hand, a moderate block could still provide a good to excellent surgical condition in a majority of patients. Consequently, the European guidelines now recommend deepening the block only if surgical condition need actually to be improved in a way to spare some blocking agent and this way reduce the related risk of postoperative complication. The task force also stated that there was insufficient evidence to recommend systematically the deblock to reduce postoperative pain, as it was suggested by some studies. Third question. What are the strategies for diagnosis and treatment of residual paralysis? The diagnosis of residual paralysis relies on quantitative measurement provided by different methods, like mechanomyography, electromyography, acceleromyography, or kinemyography, or more. Qualitative evaluation of the force of the patient is possible only with a nerve stimulator, and several decades ago, some clinical tests has been described to evaluate the ability of the patient to be extubated. Unfortunately, all this subjective evaluation fail to make the diagnosis of low degree of residual paralysis, especially since the safety threshold has been set at 0.9. In a huge retrospective evaluation of these diagnosis method, Carvalho demonstrated that compared to quantitative measurement, the risk of residual paralysis was significantly higher when using qualitative evaluation or any clinical test. These methods did not allow to improve the situation even when compared to no monitor at all. In more detail, quantitative monitoring requires the stimulation of a motor nerve and the recording of the muscle electricity, force, or acceleration. This can be done in different places. The standard is the ulnar nerve at the wrist and the adductor pollicis muscle. But it is possible to get some information from facial nerve or tibial nerve stimulation, but beware that a significant disagreement exists between the degree of paralysis measured at these different sites, with the risk of overestimation of the recovery. It is then advised that adequate recovery of the block should be confirmed by a final adductor pollicis measurement. In my opinion, it's easier and more reliable to monitor all phases of the neuromuscular block on the same hand, from the induction until the final recovery. In order to optimize the quality of the measurement, it is recommended to calibrate the monitor before administering the neuromuscular block agent. This sequence is often automatic and includes a determination of an individual supramaximal stimulation and the adaptation of the gain of the sensor to the actual signal provided by the patient. This really improves the results. When using acceleromyography. You all know that the baseline TOF ratio is frequently much higher than 100%. To overcome an obvious overestimation of the recovery, it is then recommended to normalize the ratio. That means to refer the final TOF ratio to its own initial baseline. Another way is to expect a ratio above unity, above 100%, to reduce the critical events in PACU and the postoperative pulmonary complication. Electromyography is not affected by this reverse fate. It records very small amounts of electricity in the muscle. Then consequently, it is very sensitive to electrocautery or to the proper placement of the electrodes. When using acceleromyography, it is essential to care about the installation of the hand to ensure the free movement of the thumb. It's useful to tape the finger on the armboard or to use a hand adapter, which favors the repositioning of the thumb after each contraction. It's also useful to put a soft sponge or balloon inside the hand to preserve a space for the thumb to move. In this regard, the so-called TOF tube is a prototype to install the hand and protect it from the movement of the thumb from any external disturbances. It had demonstrated its value to obtain excellent recording with acceleromyography. In all this field, the European guidelines agree and recommend the use of ulnar nerve stimulation and quantitative neuromuscular monitoring at the adductor pollices to exclude residual paralysis. Monitoring of the recovery of a depolarizing block with succinylcholine is also recommended. It is easy and possible with a calibrated train of thought. The same kind of consensus is coming from the US, stated that qualitative evaluation or any clinical test are not predictable of an adequate neuromuscular recovery. The use should be abandoned in favor of quantitative monitors. A recent UK standard recommended very clearly to use quantitative monitors throughout all phases of anesthesia, from the induction until final recovery. Whenever neuromuscular blocking agents are used. This is very clear. Finally, the treatment of residual paralysis relies on two different drugs. First, neostigmine was used for decades and well, it works. Several studies demonstrated that neuromuscular blockade reversal reduced the risk of postoperative death. Appropriate neostigmine reversal reduced the risk of PPC, which on the contrary increased when neostigmine was not administered. But high dose of an unwarranted administration of neostigmine are not safe. High dose of neostigmine, that is above 60 microgram per kilo, is dose-dependently associated with an increased risk of PPC, and unwarranted use of neostigmine, that means without neuromuscular monitoring, is associated with increased incidence of PPC because unwarranted or overdosed administration of neostigmine can impair by themselves genioglossus or diaphragm muscle function and induce some muscle weakness, leading to the same complication as residual blockade. The European analysis of the literature confirmed the higher incidence of residual paralysis after neostigmine compared to sugammadex, because it could take a long time to reverse the block with neostigmine. Consequently, it's now recommended to wait for an advanced spontaneous recovery, up to 4 responses and a TOF ratio above 20% before starting neostigmine-based reversal, and to continue quantitative monitoring until a TOF ratio above 0.9 has been reached. Another useful recommendation is simply to avoid a larger dose than 40 to 50 micrograms per kilo. Compared to neostigmine, sugammadex works definitely much better. It provides a faster reversal than neostigmine, not only as mean value, but also on the individual recovery of much faster and better TOF ratio in every patient. Interestingly, several studies demonstrated that the reduction of PPCs with sugammadex was significantly better compared to neostigmine. In a large study in the US, a lower complication incidence was demonstrated after sugammadex compared to neostigmine. It was associated with a 30 to 50% lower risk of postoperative pulmonary complication. Please note that the incidence of residual paralysis is not null after sugammadex, especially after a blind administration without monitoring or when using lower doses than recommended. Then, because of this higher rate of success to reverse neuromuscular block and preventing complication, the European guidelines now recommend using sugammadex to reverse deep, moderate, and shallow neuromuscular block induced by rocuronium. When the TOF ratio is between 0.4 and 0.9, the choice between sugammadex and neostigmine must consider the patient-related factor and the availability of each drug. And please monitor the reversal until the end, both with neostigmine and sugammadex. To conclude, we get here a very interesting set of guidelines for proper management of every neuromuscular blockade in every patient, every day, in every hospital. They will help you to facilitate tracheal intubation, to reduce laryngeal injury, even during rapid sequence induction. A deep block has to be indicated during each particular procedure. Quantitative monitoring is mandatory to eliminate the residual block from our clinical practice, and the reversal agent should be used properly with the help of quantitative monitors. The European Task Force ended its work stating that the availability of quantitative monitoring in each single operating room is a prerequisite for its appropriate application. We still have to share our knowledge in this field and to implement all this strategy in our clinical daily practice. So please do it. It's possible in every hospital, and it works, like nicely demonstrated by Bayard in Paris, as the number and the use of quantitative monitors increased, the incidence of residual paralysis was gradually reduced. I thank you for your attention, and the good news is that Guy is coming on the screen and that the webinar can continue with the second presentation. Thank you, Victoria. Thank you all.
Thank you, Dr. Dubois. It was a very interesting overview of these new guidelines. So I suggest that we move on directly to our second speech, which will be presented by Dr. Guy Camus, who just joined us. Dr. Guy Camus works at the Department of Anesthesiology and Critical Care of a general hospital in Aalst. He's one of the cardiac anesthesiologists working in the OR, but also in the ICU. His scientific interests are also within neuromuscular blockade. And specifically, Guy Camus had the opportunity to be involved in the phase studies following the development of Sugamadex. Dr. Camus, the floor is yours.
Thank you. I hope the noise is okay. Dear all, I'm terribly sorry about my delay, but that is the disadvantage of working in a hospital, I suppose. I'm convinced Philippe has given an outstanding lecture and an extraordinary introduction for my talk, although unwanted. But one of the reasons why these guidelines have been created is because of this. Okay. Good evening, everybody. Thank you, Dr. van Regenmarter. Thank you, dear Victoria. And thank you, Astrid, as well, for involving MIDI Congress in organizing this BeSARPP webcast. Thank you, Luc Leerings and MSD, for the invitation and my contribution this evening to this webcast is actually a short extraction, a kind of summary of what I presented during the MSD webinar on 26th of November 2022 and recorded in a separate video that is or will be on the MSD website. My conflicts of interest are with MSD and Senzyme, and once more this evening initiative would not be possible without the support of the company. Residual neuromuscular blockade is associated with postoperative upper airway obstruction, hypoxemia, atelectasis, pneumonia, prolonged hospital length of stay, and a higher rate of unwanted intensive care unit admission. And the evidence from this comes from volunteer studies and was then transposed to post-surgical patients. Now, in one prospective observational study, residual neuromuscular blockade was associated with a higher rate of post-op pulmonary complications in elderly patients compared with the younger ones. And Lars Eriksson tells us why elderly patients are at more risk. The cells, the tissues, being the lungs, the brains, the muscles, have become old. Now, Brandon Togioka, quite recently, the end of 2022, published a nice overview of how to optimize reversal of neuromuscular block in the elderly by choosing between Sugamadex and neostigmine. The results were fairly consistent across observational and randomized controlled trials, being that Sugamadex provided a protective effect, with the majority of studies showing 20 to 30 or even higher percentages lower relative odds of post-operative pulmonary complications for patients who received Sugamadex. Now, moreover, evidence is mounting that Sugamadex may protect against the development of post-op pulmonary complications, not only by the mechanism of reduction of residual neuromuscular blockade as such, being that about all nicotinic receptors in the body are free of neuromuscular blocking agent, but that there are other mechanisms as well. The diaphragm, for example, we already showed in 2015, the EMG of the diaphragm is impressively higher in patients, not patients, volunteers who received Sugamadex compared with those who had neostigmine as a reversal agent. Now, recently, a Chinese group continued on these findings and added data after ultrasonography of the respiratory muscles. And they concluded that sugammadex provided a more complete recovery of the expiratory muscle strength than neostigmine at a train of 4 of 0.9 or higher. Now, why is the expiration so important? Generating high expiratory pressures are essential for effective coughing and secretion clearance and during recovery, and may thus at the end be responsible for a lower incidence of PPCs, respiratory complications in a whole. Now, these Chinese authors, they showed that the median time from a TOF ratio of 0.9 to unity, 1.0, after sugammadex was 10 times as fast after sugammadex than after neostigmine. And this is an important finding as well, seeing the fact that typically after acceleromyography, the TOF ratio needs to equalize unity instead of only the 0.9. Okay, the strongest study was there. Now, the strongest study is a study dealing with data from a general population. It showed that all respiratory outcomes are in favor of sugammadex and not in a limited number. 30%, 40%, 50% reduced risk of a compound of pulmonary complications. Even more importantly, there was a continuation of that stronger study by means of the still stronger study published very recently in the British Journal of Anesthesia. And that study helps us deciding which neuromuscular blockade management to choose in patients at risk. Now, how do they come at that cohort of patients at risk? They start from the huge population of the stronger study, and then they go down. Being they go down, that means that they go to those patients that are older than 80 years or have a procedure that lasts longer than 2 hours. After that, the cases are deducted with an ASA physical status 3 or 4. And from those, for those who remain, they continue with the cases who had intra-abdominal or intrathoracic and non-cardiac surgery. Obvious, because these two types of procedures have the highest incidences of residual block. And so at the end, they come at about 4,000 sugammadex matched cases and 4,000 neostigmine matched cases. Now, the reversal of neuromuscular block with sugammadex in the still stronger analysis was independently associated with reduced odds of development of a composite of all kinds of PPCs. And again, not a little bit, but quite impressively, odds ratios of about 0.5. The precursor of this study was done by Thomas Ledowski in 2013, coincidentally 10 years ago, showing that aged ASA 3 and 4 patients had a better pulmonary outcome score after reversal with sugammadex compared with neostigmine or no reversal at all. And this was very important. The pulmonary outcome score was something quite new, but was used later on as well in numerous studies, and was a composite of white blood cell count, fever, chest X-ray that was positive, and clinical signs of postoperative pulmonary insufficiency. Okay. Concerning the use of reversal agents in obese patients, another group of patients at risk, a curious but important finding was already published in the BGA many years ago, 2006. Neostigmine is not capable, even when the TOF count is 4 on 4, to reverse that very last part of the neuromuscular blockade from a TOF ratio of 0.7 to 0.9 in an acceptable time frame. Look at the right side of the slide. In the obese patients, the time to a TOF ratio of 0.9 is almost half an hour, although the TOF ratio of 0.7 was reached after 5 minutes. So neostigmine is incapable in getting that final step in the reversal of the neuromuscular blockade. While sugammadex, when administered in an appropriate dose, obviously, has, or it is administered in non-obese patients or in obese patients, an efficient way of reversing the neuromuscular block, being in less than 2 minutes. Dosed appropriately, by the way, means on an actual body weight. That's quite important to know. Published in many studies, meanwhile, for example, in BGA as well, in the same group. Now, finally, recently, a nice single-center prospective observational study was published, including more than 700 patients divided into 4 groups, actually 8 groups. Cis-atracurium with spontaneous reversal, cis-atracurium with neostigmine antagonism, rocuronium with spontaneous reversal, rocuronium with sugammadex antagonism, and they all could have intraoperative neuromuscular transmission monitoring or not. So in fact, this makes 8 groups. Pharmacological reversal of rocuronium with sugammadex, and particularly neuromuscular monitoring during surgery, were the factors that most efficiently reduced the risk of residual blockade, as well as early and late PPCs, as you can read in the paper itself, because that's a continuation of those findings. Okay, it is logical, ladies and gentlemen, to conclude that sugammadex use might not only decrease the incidence of residual block, but also reduce the risk of adverse pulmonary events and complications associated with incomplete neuromuscular recovery, and possibly, probably, even more in patients at risk. Now, definitive proof is lacking, and the battle between believers and non-believers will continue into the future, as it is not likely that the truth will ever be proven, and we will be able to ever prove that in a prospective way, to prove it prospectively and correctly. Thank you so much for listening, and enjoy our possible further discussion. Thank you, Victoria.
Thank you. Thank you, Dr. Camus, for this very interesting, very nice presentation. I see that we have questions in the Q&A. We'll start with Dr. Dubois. So the question is, if you need deep neuromuscular blockade and you use the adductor muscle from the beginning to the end of the surgery, then your monitor will overestimate the extent of the blockade. Would you suggest to evaluate the deep neuromuscular blockade rather at the orbicularis muscle instead?
Thank you for your question. I understand 2 different questions. Is the monitoring of overestimating the recovery? It depends on the method. you use, and it could be the case more frequently with acceleromegraphy compared to electromyography, for example. Regarding the site of monitoring, you suggest to monitor the deep block, I guess, at the orbicularis muscle. And this can be done with a simple nerve stimulator of the facial nerve. And the responses are absolutely not the same as those you can get at the adductor pollicis. So yes, you can monitor something in the deep block with a tough count, not at the orbicularis muscle, but at the corrugator supercilii. It's different because those two muscles, closed muscle, are not responding the same way to muscle relaxant. So this is very important. If you do it at muscle around the eye, it's the corrugator supercilii that you should monitor. And it can get some information with tough count to monitor the deep block. But it has been demonstrated that using a PTC at the adductor pollicis is providing the same level of management for the deep block in a much reliable way. So I would recommend you to use a PTC, not the tough count, but a PTC to monitor the deep block at the adductor pollicis.
Okay, thank you. I have another question from the chat for you, Dr. Dubois. Many anesthesiologists are evaluating the blocking phase every 30 seconds, so the interval, during the surgery that can sometimes last 4 to 5 hours, maybe more. Could you please comment on the risks associated with this habit?
Well, this is what is recommended by the good clinical research practice. Not every 30 seconds, but every 15 seconds. This is the way to run a train of thought every 15 seconds. And you can do it for hours without any problem for the patient. This is why the stimulators are made for. They are validated not to injure the patient even during some hours. And in my 20 years of practice, looking at every patient in this regard, I never see any problem related to this frequent stimulation. On the other hand, this stimulation is its own trends, and I would really encourage you to do it in this way, because having more frequently the responses add more security to your analysis of the actual ratio which is provided. On the contrary, if you do it only once every 5 minutes, the result could be anything else, and you don't have this trends and disregard to the previous results, and this could induce you in huge mistakes. So your reasons are right, I think, and continue do it.
Okay, thank you. Dr. Camus, I personally have a question. You showed a lot of data demonstrating the superiority of Sugammadex over neostigmine. How do you explain that the ESA guidelines still recommend the use of neostigmine when the TOF ratio is 0.4 to 0.9?
Yes, well, that's a good question, obviously, Victoria. But I think part of the explanation lies in, although the patent in Europe and Japan is going to wean off in the middle of the year, in the middle of 2023, there still is an issue of cost price. If we like it or not, a vial of Sugammadex costs about 80-90 euros. Neostigmine, I think something like 1 or 2.5 euros, depending on the country. So there is the issue of cost price. Whether that is an issue in your personal practice, that's something you have to know as a medical doctor, but it is part of the explanation. Another issue is that actually the phase studies years ago to determine the dose finding of Sugammadex were done and sponsored by the company, were done for deep blocks and moderate blocks, being a train of 4 count of 0 and a PTC 1 and 2, one side, the other side, 2 answers on the train of 4 count. Actually, officially sponsored studies by the manufacturer, and thus taken into the file, the property file of the drug, stopped over there. I mean, the dose findings were done for a TOF count of 2, and there it ended. Meanwhile, there were studies done with Sugammadex for more shallow blocks, 3 answers, 4 answers, a TOF percent of 20%, and so on and so on. But it has not really been taken up in the prescription guide of Sugammadex, and as such, as it is a bit of the road that you are using Sugammadex in those very shallow and superficial blocks. I think that part of the story lies over there, that not only the financial issue is there, but that strictly seen, there are only limited dose finding studies for shallow blocks. 0.5 milligram per kilogram Sugammadex is enough for reversing a block of a train of 4% of 20, for example. We know that, but it is not taken in the prescription guideline of the drug by the manufacturer. I think there are 2 issues that play a role over there. But neostigmine still has a place, and we all know you can, in an acceptable time frame, reverse a block with neostigmine as long as you stay, as you stated yourself in the guidelines, in a safe frame of TOF count and TOF percent.
Okay, so when the generic for Sugammadex will be on the market, do you think neostigmine will just disappear?
I don't know, Victoria. It's a good question, obviously, but prices fall tremendously down as soon as a patent is not anymore there. We know that, well, from the history with other drugs, and that will be the same with Sugammadex, I suppose. By the way, that was the same story with rocuronium, Esmeron. Prices fall often to about 30% of the price we paid, or we had to pay, or the patient had to pay, or the society had to pay for it during the patent period. Well, you can count yourself what that will mean. I don't know, but the possibility is there that with the lower prices, the use of Sugammadex, that has already a tremendous market share worldwide, will even increase even more. No?
Okay.
We'll see.
Yeah. Dr. Dubois, I have a question from the chat. I think it's a better question for you to answer. Is there any data about the accuracy of neuromuscular block monitoring with patients when they have peripheral nerve disease, for example, diabetes patients?
Diabetes, yes, that kind of disease impacts in some way the normal neural function. Like vascular disease too, and some medicaments too, some drugs, but it's not a problem to use properly neuromuscular transmission monitor in those patients. So the transmission may be a bit adapted in their daily life, but I don't think it's a problem. And those patients are a part of those patients at risk of postoperative pulmonary complications. So I would heartily recommend to use a neuromuscular monitor in all of these.
Okay. Maybe a question.
You would add something?
No. Oh,
Yes,
maybe.
May I just add something, yes. Victoria? The only thing, at least in my experience, research experience, where there is a known weakness of monitoring devices is in the ICU. In the case of patients who have proven firm polyneuropathy. Typical cases of patients who are ventilated for days and sometimes weeks on end, and in which you try to do NMT monitoring. We published that some time ago, 2-3 years ago, in the European Journal. It was a study in collaboration with Soren Brull, actually with the monitor by Senzyme, the EMG monitor by Senzyme, which was discovered, which was one of his pearls that he himself had launched. And he was driven by EMG, and he has also market shares in the company Senzyme. But together with him, we did a study with Senzyme monitoring, EMG monitoring, I mean, other devices, acceleromyography, kinemyography devices in patients with a huge degree of polyneuropathy. All these monitoring techniques seem to fail and become quite unreliable. But that is an exemption group of patients, obviously. That is not the routine patient, fortunately, we are confronted with in our anesthesia practice. That's just a little thing between brackets, but that's something you have to take into account.
Okay, thank you. Do you both use Sugemadex in children? And if so, what dosage do we have to use? Are they any different from the adult dosage?
Well, sorry to start, Philippe, but my answer is very simple. I'm not a pediatric anesthetist, so I only seldom use it. It is, as I am not wrong, it is registered for use in children, I think older than 2 years. And as far as I know, from the little amount of studies that have been done by, amongst other, Benoit Plot in France, the dose regimen is, I mean, the dose finding is the same, being 4 milligrams per kilogram for D block, 2 milligrams for the moderate block. And then again, we are at the point where I started some time ago. The more shallow blocks, officially, there is no dose finding in the prescription guide. That is as far as I know, but perhaps, Philippe, you have more experience.
Unfortunately, no, I don't have much experience in the pediatric population, but studies are lacking in this specific population. They all have been made much later than the general population, and it's the reason why there is very few of them. But all you said is right, as far as I know. And just to answer the question, I would just to recommend the same dose as we know for adults, and to use also monitors the same way we recommend for adults. And it's only a bit more complicated in very small children under 1 year, or in infant in neonatology, which is specific population, very specific, where there is no investigation as far as I know for the moment.
But there are some safety studies in Victoria, so in children, and they all prove that it can safely be used in children. But as I said, if I'm not wrong, it is officially only registered for use in children older than 2 years.
Okay, thank you for your answers. I again have a question, maybe for also the two of you. Dr. Dubois have showed us dramatic data at the beginning of his presentation. Do you have any explanation why so many anesthesiologists still don't use quantitative neuromuscular monitoring?
Reasons? No, I don't. Unfortunately, no, we don't have any reason. It's even difficult to understand why, after more than 20 years of nice literature and editorial and lectures and congresses, it is still a problem to use it in daily practice. But I really think we are at a new period, and things are changing for the moment, and this kind of guideline will help us to do it in a better way in much more hospitals. So these figures are really impressive, in fact, and I guess that in a few years we can make some comparison and congratulate us of doing it better with a much lower incidence of complication.
Okay. Maybe one last question. After using Sigamadex for rocuronium reversal, when can we use again non-depolarizing muscle relaxants again?
Do you want? I would answer just immediately if you monitor it properly. It is recommended to wait a bit, so it's easier 1 hour or 2 afterwards. You can change the agent, but I would do it with the same rocuronium, but with appropriate monitor. It's really interesting to do it, and it has been demonstrated to be safe. Okay?
I think it's a bit odd to cite yourself, but during the phase studies, I think we were the only group who did the so-called reuse study published in the British Journal, and what that study showed is that when you use the high dose rocuronium, being 3 to 4 times the ED95, being 0.9 up to 1.2 milligrams per kilogram of rocuronium, you can, it's quite some years ago, but if I remember well, you can already 5 minutes after administering Sigamadex re-paralyze your patient, even with rocuronium in the high dose range, obviously. Or you can make your choice up to another to a steroid, non-steroidal neuromuscular blocking agent. But you can reuse rocuronium as long as you use it in the high dose range, and everything has to do with the bulk of molecules you add at that moment in the body. But it's possible.
Okay, I will try then.
It's very interesting if you need it for a patient when you have to come back in the OR, but it's very interesting. And I would just add something: do it when with titration of the dose needed to re-induce actually the block. This is obviously only possible with accurate monitoring, but this is the way to provide the just amount of new rocuronium to that patient to get into the block again. So it's really interesting, and I have some occasion to do it, and it works in both directions.
Okay, I was just thanking you, both of you, for your excellent speeches, and to everyone joining us to this webinar. And I wish everyone a pleasant evening. Thank you very much.
Thank you, Victoria. You were an excellent chair. Thank you.
Thank you.
Thank
Bye-bye,
you to the
Philippe.
audience and everybody at
Thank you,
home or
Philip.
at work.
Bye-bye. Good evening,
Thank you for
everybody.
your interest.